Hello, everyone, and welcome to today's webinar, Application of T2Magnetic Resonance for Improved Patient Care in the ICU. I am Haley Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by T2 Biosystems. To learn more, visit T2Biosystems.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. With that, I'd like to now welcome our speaker, Dr. Charikleia Vrettou, Consultant Intensivist, Evangelismos General Hospital, Athens, Greece. For a complete biography on our speaker, please click on the Presenter tab. Dr. Vrettou, you may now begin your presentation.
Hello from Athens. Good afternoon. My name is Charikleia Vrettou, and I am going in the following almost half an hour present you our experience in our ICU department with T2MR assays. As already said, I am an intensivist, so I'm not a clinical microbiologist. So I hope I will give you the opportunity to take a point of view of someone, clinician, rather than microbiologist, and how T2MR technologies can be used as a point of care method in that setting. So let me just show you, give you some information about our department. Our department is a 40-bed intensive care unit, and it is really a busy unit, which is located in a teaching hospital in Athens. It's a general unit that admits on selected cases and has more than 1,000 admissions per year. The average Apache 2 score of our patients is 18 to 20, and SOFA score is 9, and this means that our patients are very severely ill. It is a very busy department, and as such, it puts a workload pressure to the microbiology lab. Another problem we have, apart from being very busy, is that we have a lot of antibiotic resistance in our hospital. And here in this table that is offered to us by our microbiology department and Dr. Evangelia Perivoglioti, who is a microbiologist, shows the rates of antibiotic resistance of some of the most common isolates in our ICU department over the years from 2018 to 2021. And as you can notice, we have very high rates of carbapenem resistance for Acinetobacter baumannii, Klebsiella pneumonia, and Pseudomonas aeruginosa. Furthermore, one has to point that in our department, most of the cultured pathogens are Acinetobacter, Klebsiella, and Pseudomonas. So escape pathogens provide us with most of the material, infectious material in our unit. That means that we have a rate of escape positive cultures, which is well above 60 or even above 70%. So the T2MR technology, T2Bacteria, gives you the opportunity to rapidly identify in the blood escape C pathogens. Being a department with mostly in-hospital infections, hospital-acquired infections, and a high rate of escape pathogen isolation in our cultures, we decided to start using T2MR, having in mind that it could assist us to quickly identify those pathogens in our patients. So we started using it in selected patients with suspected bacteremia. And when we started, we only used it together with companion blood cultures. And we apply strict aseptic techniques when taking these samples. And here you can see a picture of one of our doctors actually inserting a central venous catheter. And when we do that in the ICU, we always have a sterile environment. So all cultures, all bottles for for blood cultures, and also the samples taken for T2MR techniques application were all obtained during the procedure of inserting a new central venous catheter and before reaching the sterile environment. So we try to keep our environment aseptic and avoid any contaminations, both from the patient or from the environment. And of course, one of the things that makes T2MR particularly, I would say, one of the things that we liked is that we didn't have to do any sample preparation. As I said at the beginning of my presentation, our aim was to use it as a point of care method. So being a simple to follow technology, T2MR allowed for non-microbiologists, after some period of training, which is actually only a few days, and then followed by some period of observation, allowed for some of us, of the consultants, and even junior consultants, to be able to use the machine independently. So we emphasized in particular the preparation of the work environment, because sampling is quite simple, and also there is no any sample preparation required. So we follow the manufacturer's instruction for the T2MR application, initially for the T2Bacteria, for the T2Bacteria panel, which can identify escape C pathogens. And here we can see some publications on the application of T2Bacteria panel for diagnosing bloodstream infections. And actually, it was had already been reported when we started using it that this method has excellent sensitivity and specificity, with a discordance rate between blood cultures and the T2 bacteria panel only below 10%. Of course, these rates were not applied to strictly critically ill populations, but also to different departments, including the emergency department. And in this study also, which was published to pathogens, the sensitivity reported reaches 100%, and the discordance rate is reported to be 14.6%. And part of it means can be, the difference between the discordance rate between publications, of course, can be attributed to different methodologies different methodologies were applied both for identifying blood culture positivity, but also for because different populations were also included in those studies. So this is again another study published in the Journal of Antimicrobial Chemotherapy. The discordance rate reported was 13.8%. And here you can see that a true infection criterion was applied to compare in order to calculate the discordance. So the methods applied for the criteria applied in order to determine discordance and concordance differ between studies. So as we started using this new technology, we also decided to keep our data and the patient's data, and of course the reports, both by the T2MR platform and also by our microbiology department, and start collecting this information in order to publish it as well. And of course, we had a totally different population than those previously published, in that we only had critically ill patients. So in our study, which was a prospective observational study, our aims were both to evaluate the feasibility of the technique as well as the diagnostic accuracy for both T2 bacteria and T2 resistance, because after a while we started applying also T2 resistance with T2 bacteria as point of care tests. That means that the whole procedure was run by intensivists. And we did not document data on patients who were on limitation of life-sustaining treatment, while we have also obtained informed consents from all included patients. In total, we included 208 cases. Only 181 were analyzed finally. As you can see in the chart, the study chart, some patients had invalid reports. Some patients had contamination identified by CNS positive cultures. And also, not all 181 cases had T2 resistance panel run as well, because we had, from time to time, we did not have consumables. So it was, as we say, a convenience sample for both T2 bacteria and T2 resistance assessment. What we used. And here you can see the T2 resistance panel that was used in combination in many cases together with T2 bacteria in our study. So see, here are some of the results in our population. On the left, I apologize for the busy slide. On the left, you can see there is a table here describing our population. I think this table is important because you can see that patients were really severely unwell. There's a mean Apache 2 of 16 and SOFA score 8. You can also see that almost 26%, not almost 26% of the population was on continuous renal replacement therapy. But what I think is very important to notice is that 93% of the population, of the patients included, were on one or more antibiotics at the time of sampling. And I think this has some important consequences on how one interprets the results. Another point you can see on the chart here, the different pathogens cultured from different samples and different methods. With the blue bars, you can see all the results obtained by the T2 bacteria technique, and Acinetobacter baumannii is our protagonist here. The red bars represent the isolates cultured in the companion blood cultures. And as you can see, Acinetobacter baumannii is again the protagonist, followed by Klebsiella pneumonia. The purple bar shows the blood cultures obtained by the patient at 5 times interval before and after sampling time. This was some additional data that we decided to document for each patient included in our study, so that we could probably use them then not only to estimate escape pathogen detection overall in our population, but also in order to make assumptions about the expected discordance. And finally, the orange bars represent pathogens identified in samples other than blood. This included bronchial secretions, as well as urine samples. And you can see that there's no bacterial growth in 70.7% of cases. One pathogen was cultured in 26% of cases, and 2 pathogens were cultured in 3.3%. So one of the results that we expected, but it's interesting, of course, and important to notice, is that the mean time from sampling to report availability, while it was 4 days in our hospital for obtaining the blood culture report and 5 days for obtaining the susceptibility testing, the antibiotic susceptibility testing, For the T2MR techniques, this time is around less than 4 hours for the T2Bacteria assay and less than 5 hours for the T2Resistance assay. So there is definitely a very clear difference in the mean time from sampling to obtaining the results. The rates of invalid reports, which we considered acceptable, were 6.7% for the T2Bacterial assay and slightly higher for the T2Resistance assay. But during the study time, we had quite a lot of support from the company's technicians, who actually supported the whole project. And whenever we had dysfunctions or invalid reports, we had quite a frequent and quick technical evaluation of the system. And here you can see our results. Actually, this table shows the comparison between the T2Bacteria panel and the blood culture results. I think the most fair table is the lower one, that shows the concordance between blood cultures and T2Bacteria regarding the escape C pathogens. And we can see here that we have, in 38 cases, we had both T2 and blood culture positives. In 14 of these cases, the T2Bacteria assay was positive with an additional escape pathogen compared to the blood culture, while in 3 cases, the T2Bacteria assay was positive, but the blood culture, which was also positive, showed a different escape C pathogen, the T2Bacteria panel. One important thing to notice that one has to keep in mind that we also documented the culture results from different samples, was that in 68.2% of the cases where the T2Bacteria assay was positive and blood culture was negative or missing an escape C pathogen, the same microorganism identified by the T2 panel was also isolated in another specimen from different sites, not in blood, not in the companion blood culture. And here you can see the overall results, the positive percentage agreement, which is comparable to sensitivity, the overall negative percentage agreement, which is comparable to sensitivity, to specificity. I think the most fair, again, is to see to check the concordance of the T2Bacteria assays with the blood culture reports for escape C pathogens. And we can see that we have quite a high positive percentage agreement. The negative percentage agreements, of course, lower, but this was expected since we knew that the technique is far more sensitive than the blood culture. So this wasn't surprising. Of course, the Cohen's kappa coefficient, this is an index of concordance, which is quite a strict index because it takes into account the probability of concordance by chance, was fair for blood culture and T2MR concordance. For the T2 resistance assay results, here you can see also the results of the 67 cases included in the analysis. The T2Bacteria assay was positive in 25 and was negative in 3 cases of the total 28 cases that were positive. In the remaining 39 cases who had the negative T2-resistant assay, 26 also had the negative T2Bacteria assay, and 13 had the positive T2Bacteria assay. So the probability of a positive T2-resistance assay was 10.34% with a negative T2Bacteria assay. And in more than half of those cases, there was one gene identified, and you can see that in our sample, KPC was the most frequently identified gene together with New Delhi, Vim, IMPERF genes. This is a table that shows how we estimated concordance, how we matched the genes identified by T2 resistance with the antibiograms that were provided by our microbiology department. And here you have the results of the comparisons, the table, similar table to that for T2Bacteria. And we can see that in 12 cases, both T2 resistance and the antibiogram were, the two were concordant. However, from these 12 samples, in 3 cases, the T2 resistance assay showed also included genes that were not expressed in the cultured pathogens. And in 2 cases, the T2 resistance assay lacked resistant genes expressed in the cultured pathogens. So they had partial concordance, actually. And of course, on the cell that shows both antibiotic resistance absent by blood culture techniques and by T2 resistance panels, these also included cases when the blood culture was negative. This was considered as concordant. And here you can see the results again for similarly as was done for T2Bacteria, for T2 resistance. And you can see that there's a very big range because apparently because the number of cases on each cell is small. So we have very large confidence intervals. So one can only have a taste of how T2 resistance performs. They are not very strong results and weaker than those we have for T2Bacteria assay. One interesting point, though, when we examine, this table shows all the discordant cases, most of them for T2 resistance, actually, most of them were of the type of T2 technique was positive and the blood culture technique was negative. But here you can see with different colors how different situations are identified. With red color, you see the cases where the T2 resistance panel missed genes that were identified in the blood samples by blood culture-based techniques, by the antibiogram. So these are the red ones. The blues are those that in those cases where the T2 resistance panel identified genes that were not found, that were not actually matching the blood culture-based methods, the antibiogram, but and in particularly those where additional genes, additional resistance genes were shown by T2 resistance panel. While in yellows, the yellows are those cases where we had, again, discordance in that there were resistance genes identified by T2 panel that was not, the resistance was not present in the blood culture sample, but the phenotypes of these pathogens were actually the resistance pattern was similar to that of a pathogen identified from different sites during the study period. So overall, the majority of the discordance was of the blood culture negative, T2 panel positive kind. So possible explanation, of course, the number one explanation is that we have greater sensitivity with the T2 MR techniques. But also another possibility is that because since our patients are critically ill, it's likely that many of our patients have concomitant low-level bacteremias or transit bacteremias that were not identified in blood cultures. And here, I think an important player is the rate of antibiotic administration on our population. If you remember, more than 90% of our population was on at least one antibiotic at sampling time. So chances are that genetic material, even from dead microorganisms, may be present in the circulation. So, of course, our study has limitations, single center, and there was no the possibility for systemic molecular testing for resistance genes. So we had to be based to blood culture methods, and particularly to antibiotic susceptibility testing in order to identify the pathogen phenotypes. While, of course, due to the scarcity of infections by certain pathogens, the sampling size was too small to correspond positive percentage and negative percentage agreements accurately. So, nevertheless, it was one can safely say that the T2MR panel can be of help, can help clinicians to make decisions on antibiotic treatment. And what is striking is, of course, the excellent sensitivity or excellent negative predictive values that we had for the technique. So one can use this method in patients suitable for de-escalating antibiotics, but also can be used for more informed decisions on choosing appropriate antibiotics for initial antibiotic therapy. So rather than just using results of base empirical antibiotic decisions only on data from overall, only from epidemiological data, can also have a more informed, make a more informed decision by using the T2Bacteria and in combination, or either a single method or in combination with the T2Resistance panel. And this slide actually refers to, again, our hospital and our clinical situation. De-escalation is a clinical task which is not easily performed. For example, we have some data from our department where we monitor de-escalation while using the T2 MR panel, and we didn't follow a strict protocol for this. However, the de-escalation rate, only by informing clinicians for the T2Bacteria reports, reached 11.5%, and this may not be very impressive. However, one needs to remember that the overall de-escalation rate increase is rather low. So we think that the T2 platform can be of use for this, can help, and also, of course, for a more informed initial antibiotic strategy. I'm going to continue with a few examples and try to finish on time. I have a couple of more minutes. So I'll show you some examples of how we have used the T2MR in the unit. In the first case, I'm going to describe the situation when a 36-year-old patient was admitted to the unit with coma after traumatic brain injury. So the patient was intubated in the accident and emergency department with epileptic seizures and also severe head trauma, was admitted to intensive care unit, and the patient had severe intracranial hypertension. And when we have this problem, we know our patient is going to stay sedated and intubated for days. So requiring a prolonged sedation in the intensive care unit, the patient had to undergo a tracheostomy on day 12. And on day 13, after the tracheostomy was done, actually the patient became febrile. So blood cultures and imaging were ordered, and we started on empirical meropenem, vancomycin, and colistin according to local antibiotic susceptibilities. And colistin is usually with meropenem, is added to meropenem, since we have very high rates of meropenem resistance in our pathogens. So the computerized tomography showed that the sinuses were blocked. There was no another sepsis source identified. The catheters were, of course, changed, and the sinuses were drained from this fluid from this pus. KPCK pneumonia was cultured, so the antibiotics were modified to ceftazidime avibactam on day 17. 24 hours after antibiotic de-escalation, the patient became worse, actually. He became hypotensive. He had to be resuscitated with crystalloids. An noradrenaline infusion was initiated, and new blood cultures were ordered. And since we decided to change the CVC, the patient was included in our study. Actually, we had T2Bacteria panel T2Bacteria and T2Resistance, but the T2Bacteria panel actually revealed Pseudomonas aeruginosa. So having actually modified antibiotic treatment to only Ceftazidima vibactam, we decided to add colistin to cover for Pseudomonas, since in our hospital we don't have any resistance of Pseudomonas to colistin. So the blood culture actually became back 72 hours later. That was positive as well for Pseudomonas aeruginosa. However, within 3 hours, we had the report from the T2Bacteria panel, and so we avoided the unnecessary use of gram-positive coverage, and we targeted our treatment to Pseudomonas, which was actually the pathogen identified also by the blood culture in that case. And the patient followed an uneventful clinical course thereafter. And here I show you another case, a 70-year-old patient with COVID-19 that was during the second phase of the pandemic, who was admitted to our hospital with hypoxemia. But the patient had the complicated past medical history from rheumatoid arthritis under steroids, coronary artery disease, diabetes, and hypertension. During the hospital stay on the ward, the patient became pyrexial. He had blood cultures sent, and there was no apparent source of infection. The patient was on empirical antibiotics, meropenem and colistin. However, 1 week after hospital admission, the patient developed worsening respiratory failure, became severely unwell with hemodynamic compromise. He had to be intubated. He had hemodynamic support with vasopressor, empirical antibiotics, and was transferred. So while in the unit, we had the reports from the blood cultures that were taken in the department and the ward, and these were positive for K pneumonia, which was a KPC actually, and Candida albicans. The antibiotics were modified to meropenem and ertapenem plus an antifungal for Candida. The patient was on high-dose vasopressors, and steroid supplementation also initiated, and the patient improved. So 2 weeks later, so his antibiotic scheme was then further modified to ampicillin, sulbactam, colistin, and caspofungin for PDR, A. baumannii, and Candida albicans at that point. However, his renal function was deteriorating with raising urea and creatinine, and there were worries that the patient would have to be started on continuous renal replacement therapy in the ICU. However, while the patient was still in our departments, he suddenly became unstable hemodynamically. We also, again, had to initiate high-dose vasopressors and started looking for a new sepsis source. Of course, we changed the line, and we requested blood cultures, and samples for the T2Bacteria were also sent. We requested a new chest X-ray, and we showed bilateral pleural effusions. And of course, renal function was also deteriorating, and the patient was at risk of needing further catheters and the immediate initiation of renal replacement therapy. So escalating antibiotics was considered at that stage. However, we decided to check a T2Bacteria first, because we were actually, we wanted to find out, we wanted to better actually have more evidence on adding antibiotics to a patient at risk of renal failure. T2MR report was negative, and that made the clinicians actually questioning the sepsis diagnosis for this patient. We then checked the SCVO2, the oxygen saturation of the superior vena cava of the patient, which was only 60%, which is something that we don't usually see in septic shock. It's more related usually to hypovolemia or cardiac dysfunction. So cardiac ultrasounds showed normal contractility, but a collapsing inferior vena cava, so the patient was severely hypovolemic. So we decided to keep the existing antibiotics and actually modify the dose, lower the dose to renal dose, and to increase our dose of steroids and administer more fluids. And on fluids and steroids, the patient actually improved. The blood cultures came back negative from that patient 1 week later, but in the meantime, the patient was already off the ventilator and didn't need to undergo continuous renal replacement therapy. So I would say to conclude that the T2 platform, the T2MR platform was assessed and as an easy to use analyzer. It showed excellent negative predictability for escape C pathogens, even as a point of care techniques. And the T2 platform results can provide timely support to clinicians, can assist empirical antibiotic selection, antibiotic de-escalation, and of course antibiotic escalation in selected cases, while the T2Resistance panel may provide additional information in selected cases. Of course, T2MR can support clinicians to make informed decisions, but of course we have to take into account as clinicians other factors such as the clinical, the epidemiological, and the laboratory data that are available for the patient. So here I conclude my presentation, and I don't know, I want to thank you for your patience, and I will be, of course, available to listen to questions if there are any. Thank you.
Wonderful. Well, thank you so much, Dr. Vrettou, for your informative presentation. If you would like to turn your webcam off, you can do so. That'll help preserve some of our bandwidth here since we're still seeing a few delays on your side of the webcam. So if you would like to turn that off, you're more than welcome to. But we will now start the live Q&A portion of the webinar. And to our audience, if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so we've already got some great questions coming into the chat here. So we'll go ahead and start with this one. Dr. Vrettou, this first question asks, what steps did you take, or what data did you or your team need to generate in order to build clinical confidence in the T2 test results?
Okay, thank you for the question. So I think the data that we generated and were based on were, of course, the statistics of the study that I showed you that showed a very good negative predictive ability of the T2 techniques, but also, and I would say, acceptable positive percentage agreement. So I think during the study period overall, more clinicians became more and more confident and showed more, they were not afraid to base their decisions in the T2MR platform. They felt more and more confident on using it. I think the concordance with the blood cultures, the concordance rates were the most important factor, though, that assisted clinicians in making an opinion, in forming an opinion on how to actually use the T2MR platform.
Wonderful, thank you. All right, this next question here asks, looking at some of the results that were negative for T2, were you able to do anything differently regarding patient treatment or care with a negative result?
Yes, of course. In the second example that I showed you, we had such a case in which we did not escalate. And for this patient not escalating, this patient who had an already affected renal function, it was very important for him. I think it was a very good thing that he didn't have to take high doses of more antibiotics that who could have affected the renal function. And while the patient had a sepsis mimic, he wasn't really septic. But on many occasions, when clinicians, when we want actually to stop antibiotics early in cases that do very well, in case of bacteremia, we now request also the T2MR report, so that if that comes negative, given the fact that this technique has very high sensitivity, and that we have when we have a patient who actually is looking much better, and the negative result helps us, supports our decisions for the early discontinuation of antibiotics. These are some examples of cases where the negative result is very useful. But even if the T2Bacteria report is positive, the T2Resistance negative result can also be of help in that if we have, for example, Klebsiella, but then we have a negative T2Resistance report, that means that this Klebsiella is likely to be sensitive to meropenem or the combination of meropenem and colistin, and we don't have to use newer beta-lactam antibiotics or combinations of new combinations of beta-lactam and lactamases, anti-lactamase combinations to treat those infections. So I would say that negative results are particularly useful. And they also make sense because to use them because of the excellent negative predictive abilities of these techniques.
Great, thank you. All right, well, we do have time for a few more questions here, so we'll continue. This next question asks, do you plan to expand testing outside of the ICU, for example, oncology units, emergency department, etc.?
Yes, I think from our experience in the ICU, any place where escape pathogens, any department that has high rates of escape pathogen detection can definitely benefit by using it on a similar manner as we use it. But different departments would have probably different ways of utilizing the reports. I would say that wards that treat immunocompromised patients, such as oncology and hematology departments, could use it. At the moment, in our hospital, we use it only in the ICU as point of care. So this technology is not actually applied in the microbiology lab in Athens. So in our hospital, because apparently the platform is also used in different hospitals. But it would make sense to do so, to include hematology and oncology wards, and definitely even transplantation wards.
Great, thank you. All right, this next question says, I may have missed this, but what was the rate of mixed infections or co-infections in your population?
No, I think I cannot comment because I'm not sure what the question asks. What does mixed infections mean?
All right, we'll see if we get any further clarification on that one. So we'll skip that for now.
Yes, I can probably comment on this, but I don't know if that helps, the study was that the data that I present was also only comparing between blood culture reports and T2MR reports. So it only had to do with blood infections. But what may have caused, I think, some confusion is that in the discordance discussion, I showed you cases where the pathogens, the T2MR identified pathogens, were not cultured in the blood, but were cultured in different samples. However, the aim of our observational study was not to classify patients in having pure blood infections or combination of chest, blood, or urine infections. We only included this data in order to make assumptions about discordance. So we actually did not have this classification in our methodology. I don't know if that helps the person who asked, had this question, if that makes it more clear.
Yeah, and we did get some further notes here. So we saw that they were asking in regards to mixed infections, more than one pathogen in the sample, co-infections, multiple bacteria recovered on one panel.
Okay, can I go back to my presentation then?
Of course.
Yes, I can. Yes, okay, so this rate is actually included in the presentation. So we will check the escape pathogen table, because I think this is the more accurate, because T2MR only detects escape pathogens. So as you can see, with the T2 positive, BC positive, in the T2 positive, BC positive cells in 14 cases, the assay, the T2 assay was had an additional escape pathogen, so it had more than one pathogen. And I think, sorry, maybe we can see it more clearly. No, these are other results, sorry. Yeah, I cannot find this result. Okay, however, nevertheless, one can get an idea. There was a high rate. I cannot find it in the presentation now, where we had more than one pathogens, and so in our population. However, what that affects is the concordance. Because you may have positive culture for escape, positive T2MR panel, and this may be rated as concordance, while the concordance is only partial concordance. This may have helped a little bit the concordance rate of the T2MR technique. Apologies for, I cannot find this result now in my presentation. Maybe I have deleted it.
That's no problem. And we have that attendee's information, so we can always follow up with an answer afterwards as well.
So, if you give me one moment.
Sure.
Yeah. Okay, so one pathogen, there was in the 26%, two pathogens in 3.3%. So from the microbiology reports, okay? So in the, there was no bacterial growth in 70%. So we would say that it's below 30% for the blood culture techniques. For the T2Bacteria reports, the T2Bacteria results, of course, they were positive in 49.7% of the cases. One pathogen was identified in 64.4%, and two or more pathogens in 35.6%. So the multiple pathogens were identified by the T2MR technique in a little bit higher, 5% approximately, while they were identified in less than 5% of the blood culture reports. Does that help?
I'm sure that does. That was a wonderful explanation. Thank you so much.
I had to check the results of the publication, actually, because for some reason I forgot to include that.
Well, thank you for checking that. All right, great. Okay, well, it looks like we have time for about one more question here, so we'll go ahead and wrap up after this one. This final question asks, are you able to test pediatric population?
Evangelismos Hospital does not have a pediatric ward, but definitely could be used, I think, for pediatric populations, because I think what makes the important distinction is between in-hospital and acquired infections and community-acquired infections, because in-hospital infection in Greece are escape pathogens to a great extent. While out of hospitals acquired infection, the rates of escape are lower, but they are rising. So pediatric population, if we had a pediatric ward, it wouldn't be an issue. I don't see why they would differ. The only thing taking into account is that you have to take some more blood. But given that for each bottle of blood culture, you have to fill in with 5 or even 10 mLs of blood, the 4 mLs for the T2MR sample, I think, are acceptable.
Wonderful. Well, thank you so much, Dr. Vrettou, for your time today and your important research. Do you have any final comments for our audience before we go?
Well, I have one comment. I think that different platforms, different technologies can be used in different ways in different places. So I try to give you a flavor of how we use the T2MR platform in our department, but the needs of all the departments may be different. So the strategies may also be different. And it is a clinical decision, I think, on how one wants to use this technology. So I hope that these results will help clinicians to make more informed decisions in the future.
Great. Well, thank you again for joining us today. We would also like to thank LabRoots and our sponsor, T2 Biosystems, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.
Bye-bye.